Atropine is a naturally occurring alkaloid. It is a muscarinic receptor antagonist. Thus, it prevents the effect of acetylcholine by blocking its binding to the muscarinic receptor. In general, muscarinic antagonists cause little blockade of the nicotinic receptor. Atropine is tertiary amine, thus it can easily cross the blood-brain barrier. The naturally occurring atropine is found in the levorotatory form, whereas the commercial preparation is of racemic mixture. The racemic mixture means 50-50% mixture of two enantiomers. Enantiomers are the stereoisomers, that means the molecules with the same molecular and the structural formula. Basically, these are the mirror image of each other. The atropine are the alkaloids of the belladonna plants. Preparation of the belladonna were known to ancient Hindus and have long been used by physicians. Atropine was isolated in pure form in 1831. If we see the structure of the atropine, it is composed of a tropine and the tropic acid. So one is the acidic part and one is the base part. So neither this free acid or nor the basic alcohol exhibit significant anti-muscarinic effect. An intact of ester of tropine and the tropic acid both are required for the anti-muscarinic action. Mechanism of action: atropine basically compete with acetylcholine for its binding site on the muscarinic receptor. The antagonism of the atropine is competitive. Thus, the effect of the atropine can be overcome by the acetylcholine if the concentration of the acetylcholine at the muscarinic receptor is increased sufficiently. Pharmacological effect of atropine. The atropine has effect on the various systems of the body. Cardiovascular system. The main effect of the atropine is to alter the heart rate. The dominant response is the tachycardia. The larger dose of the atropine cause progressive tachycardia by blocking the M2 receptor on the SA nodal pacemaker cells, thereby antagonizing the parasympathetic tone to the heart. But when it is given in the suboptimal dose or in the lower dose, that may causes also bradycardia. This unexpected effect is seen due to the block of presynaptic M1 muscarinic receptor on the parasympathetic postganglionic nerve terminals in the SA node. In infants and elderly and the patient with heart failure, even larger dose of the atropine may fail to accelerate the heart rate. When there is inhalation of the irritant vapors, pressure on the eyeball, peritoneal stimulation, stimulation of the carotid sinus, injection of contrast dye during cardiac catheterization, all this may causes cardiac slowing or asystole due to the vagal nerve stimulation. This reflex vagal cardiac slowing or asystole can be abolished by the atropine. The removal of vagal tone to the heart by atropine may facilitate AV conduction. Atropine also shortens the functional refractory period of the AV node, thus increases the ventricular rate. Circulation. Atropine alone has little effect on the blood pressure because most vessels lack significant cholinergic innervation. In toxic and occasionally in therapeutic doses, atropine can dilate cutaneous blood vessels, especially those in the blast area. This is called the atropine flush. Effect on the respiratory system. Atropine can cause some bronchodilation and decreases the tracheobronchial secretion in normal individuals. But its effect on the respiratory system are more significant in patients with respiratory disease than the normal individuals. The bronchoconstriction caused by histamine, bradykinin, these are inhibited by the atropine. This bronchoconstriction is inhibited by the atropine. Atropine inhibit the secretions of the nose, mouth, pharynx and bronchi. For that, it dries the mucous membrane of the respiratory tract. Reduction in the mucus secretion and the mucociliary clearance can result in the mucus plugs. This is potentially undesirable side effect of atropine in patient with airway disease. Effect on the eye. Atropine can block the cholinergic response of the pupillary sphincter muscles and the ciliary muscles. Basically, pupillary sphincter muscles of the iris that causes the constriction of the pupil and thus control the light entry into the eye. As the action is blocked, it causes the pupil to dilate. It is called the mydriasis. The effect of the ciliary muscle is to control the lens curvature, and when it is blocked, it causes the paralysis of the accommodation. This is called a cycloplegic response. The wide pupillary dilatation results in the photophobia. This cycloplegic response causes lens to fix for the far vision. Near objects are blurred. Objects may appear smaller than their actual size. Conventional systemic dose of the atropine have little ocular effect. When it is applied locally, the accommodation and the pupillary reflex may not fully recover for 7 to 12 days. Atropine and the muscarinic receptor antagonist administered systemically have little effect on the intraocular pressure. But in the patient with angle closure glaucoma, the intraocular pressure rises dangerously. This rise in the pressure occurs when the anterior chamber is narrow and the iris obstructs the outflow of the aqueous humor into the trabeculae. But in case of the open angle glaucoma, the rise in the pressure is very unusual, so atropine can be used in the open angle glaucoma. The parasympathetic nerves enhance the GI tone and increases the motility, relaxes the sphincters, and thereby all this favor the passage of the gastrointestinal content. Atropine inhibits this parasympathetic response, thus it causes prolonged inhibitory effect on the motor activity of the stomach, duodenum, jejunum, ileum, and the colon. And this is characterized by reduction in the tone and the amplitude and the frequency of the peristaltic contractions. But to do so, large doses are required because the enteric nervous system can regulate the motility independently of the parasympathetic control. Atropine can completely abolish the effect of exogenous muscarinic agonist on the GI motility and also in the GI secretion, but it does not completely inhibit the GI response to vagal stimuli. Gastric acid secretion. Atropine can partially inhibit the gastric acid secretion response to vagal activity. Vagal stimulation of the gastric secretions is mediated not by acetylcholine. It is by the peptidergic neurons in the vagal trunk that release the gastrin releasing peptide GRP. This GRP stimulates the G cells to secrete the gastrin. Gastrin acts directly on the parietal cells to promote the acid secretion. Also, the gastrin stimulate enterochromaffin-like cells to release histamine. Histamine also acts as agonist on the parietal cells to promote the acid secretions. Thus, gastrin, histamine, acetylcholine, all three are agonists at the parietal cells for the acid secretions. Atropine will inhibit only the component of the acid secretion that result from the muscarinic stimulation of the parietal cells, from the muscarinic stimulation of the ECL cells that secrete the histamine. For that reason, atropine only able to inhibit gastric acid secretion partially. Salivary secretion is particularly sensitive to inhibition by the atropine. Thus, the mouths become dry and swallowing and talking may become difficult. The gastric cells that secrete the mucin and the proteolytic enzymes are more directly under the vagal influence, and atropine selectively decreases their secretory function. Urinary tract. Decrease the normal tone and the amplitude of contraction of the ureter and the bladder. Biliary tract. It has mild antispasmodic action on the gallbladder and the bile duct. Opioid usually causes spasm of the biliary duct, also increases the pressure of the bile duct. Atropine though has antispasmodic action on the bile duct, but it is not sufficient to overcome the spasm or the pressure increased by the opioid. Sweat gland and temperature. In the small doses, inhibit the activity of sweat glands, thus the skin becomes hot and dry. At larger doses or when it used at the high environmental temperature, the sweating may depress at that point and that causes increase in the body temperature. Atropine is a tertiary amine, thus it can easily cross the blood-brain barrier and produces some CNS effect. At therapeutic doses, the CNS effect is minimal. There is mild stimulation of the parasympathetic medullary center noted. The central excitations becomes more prominent at the toxic doses. These include restlessness, irritability, disorientation, hallucination, delirium. When the dose increases further, the stimulation is followed by depression that is associated with circulatory collapse and respiratory failure after a period of paralysis and coma. The half-life of atropine is 4 hours. About the half of the administered dose is eliminated via the hepatic metabolism, and the remaining portion get excreted from the kidney in unchanged position. Atropine is the first-line therapy for symptomatic bradycardia, where a slow heart rate causes hemodynamic compromise or is associated with sinus node dysfunction. It is also used for the treatment of organophosphorus or muscarinic poisoning. Atropine is used as an antidote to counteract the effect of excess acetylcholine caused by poisoning from organophosphorus pesticides and certain mushrooms. It can be used as anti-sialog or antivagal effect before the operation. It reduces the secretion in the respiratory tract before the surgery and during the rapid sequence intubation, particularly in children who are more prone to bradycardia following intubation. It is also used in case of amblyopia. Atropine eye drop 1% are used to temporarily blur the vision in the unaffected eye to encourage the use of the weaker eye in children with amblyopia. Atropine is the most potent cycloplegic agent, causing temporary paralysis of the ciliary muscles, and it is used for cycloplegic refraction to determine refractive errors during the eye examination. The absolute contraindications of atropine are obstructive uropathy, GI obstruction as seen in the pyloric stenosis or paralytic ileus, intestinal obstruction, angle closure glaucoma, hypersensitivity or allergy to the drug. The relative contraindications are coronary heart disease, acute myocardial ischemia, congestive heart failure, tachycardia, hypertension, obstructive lung disease like asthma, COPD, myasthenia gravis, thyrotoxicosis, older adults, as older patients are much more sensitive to atropine effect, especially those affecting the central nervous system like the confusion and the delirium. The effect of atropine in relation to dose. At 0.5 mg, it causes slight cardiac slowing, some dryness of mouth, inhibition of sweating. At 1 mg, it causes definite dryness of mouth, thirst, acceleration of heart rate, sometimes preceded by slowing, mild dilatation of pupil. At 2 mg dose, it causes rapid heart rate, palpitation, marked dryness of mouth, dilated pupil, some blurring of near vision. At 5 mg dose, the previous symptoms becomes marked: difficulty in speaking and swallowing, restlessness, fatigue, headache, dry and hot skin, difficulty in micturition, reduced intestinal peristalsis. When the dose is more than 10 mg, it causes the previous symptoms becomes more marked: pulse rapid and weak, iris practically obliterated, visions very blurred, skin becomes flushed, hot, dry and scarlet, ataxia, restlessness, excitement, hallucination, delirium and coma.